students, in this segment I will discuss with you management of tachycardia and tachyarrhythmias. So how do we define tachycardia? Simple, we know that normal heart rate ranges from 60 to 100 beats per minute, and if it is above 100 beats per minute we call it tachycardia. So with heart rate greater than 100 beats per minute we call it tachycardia, and if the rhythm of the patient is not following the PQRS pattern, it's a non-sinus rhythm, then we call it tachyarrhythmia. So for tachyarrhythmia, the rhythm has to be non-sinus rhythm. And remember, there is variety of different type of tachyarrhythmias, right? So we have different type of tachyarrhythmias, and management depends upon recognizing that what kind of tachyarrhythmia is present in the patient, right? Accordingly we have to manage. So it is very, let's say, advisable to know that if patient is having high heart rate, what type of tachyarrhythmia it is, and definitely our management would depend upon that. So let us say our management depends upon the tachyarrhythmia is stable or unstable. Now what do I mean by unstable tachyarrhythmia? I mean that because of tachyarrhythmia, patient is having some symptoms. Now what do I mean? Patient is having high heart rate, and there are signs and symptoms present in the patient, and those signs and symptoms are because of that high heart rate. Then we call it unstable tachyarrhythmia. Now whenever we receive a patient with a high heart rate, we always very quickly should understand that sign and symptoms present in the patient is because of that high heart rate or because of some sign and symptoms like pain due to acute MI, right, is causing that increase in heart rate. So we have to very fast identify this, though in many circumstances it is difficult to identify. Okay, if the tachyarrhythmia is unstable means causing symptom. What symptom? I will tell you in few minutes. Then irrespective of type of tachyarrhythmia, we have to cardiovert. So cardioversion, we have to give electricity to the patient. That only is the only management of unstable tachyarrhythmia. And for stable tachyarrhythmias, we have to use antiarrhythmic agent according to the type. Now, what are the clinical features of unstable tachyarrhythmia? Now, if the heart is beating so fast that the cardiac output of the patient is reduced, then because of that low cardiac output, perfusion of the vital organ will get affected. What will happen? Because of low cardiac output, pulmonary edema can happen, acute chest pain can happen, right? Patient can have a syncope, poor perfusion to different vital organs will happen. And number of times because heart rate is very high, heart is beating ineffectively, and there is incoordination between atria and ventricle. Again, the cardiac output is not being maintained, and because of that we will get a typical clinical features of low perfusion like hypotension, altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. Okay, these are signs of unstable tachyarrhythmia. And remember, these were the signs of unstable bradyarrhythmias also. Now, irrespective, I receive a patient with tachycardia or tachyarrhythmia, and the patient is having these symptoms which I just now discussed. Now, irrespective of the type, the management would be same. I immediately, when I receive a patient with a high heart rate, I will attach oxygen, I will put monitors, I will put an IV line, I will do a 12-lead ECG, I will measure the blood pressure of the patient, I will do all the things which will try to stabilize ABC of the patient. Airway, breathing, and circulation. So I will try to assess all these three things. Then only I will get the sign and symptoms whether because of tachyarrhythmia is present in a patient or not. And if possible, I will try to identify the cause. If I can find a cause, what is causing this, why this tachyarrhythmia is present in the patient. Because if I identify the cause, let's say fever is causing tachycardia in the patient or tachyarrhythmia in the patient, I will treat the cause and try to remove the tachyarrhythmia, not treat the tachyarrhythmia per se. Okay? So when I receive a patient, I will do all these things. If I have time, immediately I will do a 12-lead ECG also. 12-lead ECG. Okay? and if patient is unstable, immediately I have to cardiovert, a synchronized cardioversion. Well, when a patient is in cardiac arrest, we don't cardiovert, we defibrillate. We give an unsynchronized shock. But here we are doing a cardioversion. That is, we are giving a impulse. We are delivering a shock by using a sensor that synchronizes delivery of that shock during peak of QRS complex. During peak of QRS complex. Right? Why? Because we don't want to deliver the shock during cardiac repolarization, which is seen on the surface ECG as the T wave. So we don't want to give, because if I give shock during T wave, then there is a chance that patient can go into ventricular fibrillation. So we try to cardiovert. And remember, for cardioversion, less amount of let's say less joules of energy would be required, which would again be beneficial. It will cause less damage to the cardiac muscle. Okay, so we will cardiovert irrespective of any type of tachyarrhythmia if it is an unstable tachyarrhythmias. Now, for different type of tachyarrhythmia, which further I will tell you how to recognize it, we have different type of tachyarrhythmias with a different energy level for cardioversion. Right? Different tachyarrhythmia requires different energy level for cardioversion. That's why we are saying that you need to do a 12-lead ECG as soon as possible to try to recognize the rhythm which is causing tachyarrhythmia. Though management of all unstable tachyarrhythmia is a cardioversion, but depending upon the type of tachyarrhythmia, we will give accordingly the energy level to the patient. Right? If patient has unstable atrial fibrillation, 200 joules of energy is required for cardioversion. If unstable SVT or atrial flutter, then 50 to 100 joules is required for cardioversion. Unstable regular monomorphic tachycardia with pulse, 100 joules is required. And if it is polymorphic ventricular tachycardia, not monomorphic, polymorphic, then we cannot cardiovert because there is no synchronization, no pattern in the ECG, right, for the sensor to recognize the peak of R wave. Then we have to use defibrillation. Then we don't have to cardiovert. In polymorphic ventricular tachycardia with pulse, an unstable patient, in spite of being patient unstable, patient has pulse, we have to defibrillate. We don't have to cardiovert. And you know, normally polymorphic ventricular tachycardia immediately changes into ventricular fibrillation or becomes ventricular tachycardia pulseless. Then we have to manage on the line of cardiac arrest. Okay. Now let us talk about stable tachyarrhythmia. In this, one by one, I'll talk about different tachyarrhythmias, and I will tell you how to do a recognition through ECG, right? And what is the management. Okay, so let us talk about stable tachyarrhythmia. To treat stable tachyarrhythmia, we first need to recognize the type of tachyarrhythmia. So when do we call tachyarrhythmia, and how do we differentiate between different tachyarrhythmia? We have to understand. So let's say if heart rate is more than 100, then we call it tachycardia, and if the rhythm is non-sinus rhythm, then we call it tachyarrhythmia. So if heart rate is more than 100, then what we see? We see QRS complex. QRS complex, the length of QRS complex, if it is above 0.12 seconds. If the QRS complex is above 0.12 seconds, then we call it broad QRS complex tachyarrhythmia. And there are two reasons, two etiologies, broad etiologies for broad complex tachyarrhythmias. First one is ventricular tachyarrhythmia, and the second one is supraventricular tachyarrhythmia with an aberrant pathway. Supraventricular tachyarrhythmia with aberrant path. Okay. If QRS complex is less than 0.12 second, that is less than if let's say the length of QRS complex is less than 3 small boxes, less than 0.12 seconds, then it is called narrow complex tachyarrhythmia. And in narrow complex tachyarrhythmia, first thing we have to see whether the rhythm is regular or irregular. So first, next, how we differentiate whether the rhythm is regular or irregular. So if the rhythm is regular, then there is two possibilities. If we can see P waves followed by QRS complex, that is a sinus pattern, then we call it sinus tachycardia. Sinus tachycardia. And if it is not PQRS pattern, we cannot see the P wave, but the rhythm is regular and it is a narrow complex, then it is paroxysmal supraventricular tachycardia, popularly known as PSVT. So if it is not sinus rhythm, non-sinus rhythm, then it is PSVT, paroxysmal supraventricular tachycardia. If the rhythm is irregular, then there is two possibilities. We'll talk in detail: atrial flutter or atrial fibrillation. Okay, so this is how we classify the tachyarrhythmia in narrow complex tachyarrhythmia and broad complex tachyarrhythmia. Okay, now let us start with the narrow complex tachyarrhythmia first. Now, why narrow complex tachyarrhythmia? What is the origin of narrow complex tachyarrhythmia? Remember, the origin of narrow complex tachyarrhythmia is nodal, either SA node or AV node. And SA node origin, there is only one tachycardia, that is sinus tachycardia, right? Well, SA node is overexcited and start discharging the impulse at a very fast rate, and we get a sinus tachycardia, which is mostly physiological. And AV node origin, other tachyarrhythmias, the narrow complex tachyarrhythmias are of AV node origin. Now remember, when the rhythm passes through the normal conduction system of the heart, right? When the impulse, not rather rhythm, impulse passes through the normal conduction system of the heart, that is from SA node to AV node through bundle of His, right? When it is passing the normal conduction system, the ventricle is contracting at a very fast rate, and that is why we are getting a narrow complex, that is narrow QRS complex, right? And if the impulse is not following the Purkinje system, the bundle of His, right, it is not following the normal conduction system of the heart, then the ventricle is taking time to contract. All the parts of the ventricle is taking some time to contract. Then we get a broad complex, we get a broad QRS complex. Got my point? So narrow QRS complex tachyarrhythmias are mostly of nodal origin, and this type of tachyarrhythmia follow the normal conduction system of the heart. Okay, so as I told you, regular or irregular. Regular means sinus tachycardia, which has a sinus rhythm, only the heart rate is more than 100, and supraventricular tachycardia. Irregular, we will discuss two: atrial fibrillation and atrial flutter. So let us start with sinus tachycardia. Okay, so how do I recognize sinus tachycardia through ECG strip? First, we see the heart rate. It should be above 100 beats per minute. Then we see the QRS complex. It should be less than 0.12 seconds. The width should be less than 0.12 seconds, right? PQRS pattern should be followed. That is, one P wave should always followed by a QRS complex. So PQRS pattern should be followed. Then we call it sinus tachycardia. Okay. Now mostly the sinus tachycardia is due to some other diseased condition. As per se, it is not a primary disease. That is why treatment of sinus tachycardia is not required. Rather, we have to treat the cause because of which the sinus tachycardia is happening. It's a physiological response of the body due to some disease condition. So few points about sinus tachycardia. Sinus tachycardia, as I told you, heart rate greater than 100, and it is generated by sinus node discharge, fast sinus node discharge. Gradual onset, gradual termination, right? mostly due to external influences on the heart, due to like fever, anemia, your hypotension, blood loss, hypothyroidism. These can cause sinus tachycardia, and we never cardiovert it. We never use a cardioversion. We never use a cardioversion because when we try to cardiovert sinus tachycardia would rather increase rather than decreasing. Okay, so our goal in sinus tachycardia is to treat the underlying cause, not to treat the sinus tachycardia. Okay, so this is about sinus tachycardia. Now coming on, the narrow QRS complex, a very important narrow QRS complex tachyarrhythmia, atrial fibrillation. Now, what is atrial fibrillation? Just remember by the name, atrial fibrillation. Atria is fibrillating. What do I mean by this? Atria is discharging impulse in a random, irregular manner. In a random manner, it is generating impulses in a very random manner, right? And because of this random impulse generation from atria, the impulses which travel to AV node, some can be taken by the AV node, some cannot be taken by the AV node. And because of this, the pulse rate which we get is irregularly irregular. Typically, we get irregularly irregular pulse rate. So, what is atrial fibrillation? As I told you, conduction through atria in a random and unpredictable manner. Impulses are sent to AV node at a random intervals, not at a regular intervals, and typically we get irregularly irregular pulse rate. So in ECG, how do I recognize it? So this is a typical AF ECG, in AF waveform in a ECG strip. You can see here, first thing, the pulse rate should be above 100 beats per minute, right? Then RR interval should vary. There should be variable RR interval, right? RR interval should vary. No normal P-wave morphology. P-wave morphology. I won't say a normal P-wave morphology. So I wouldn't say a proper P-wave morphology. Rather, we would see a fibrillating P waves around the baseline. So we will get a fibrillating P wave around baseline. We'll get a fibrillating P wave around the baseline. Got my point? Okay. So as I told you, in atrial fibrillation, first thing, pulse rate should be high. QRS complex should be narrow. QRS should be less than 0.12 seconds. This is narrow QRS complex tachyarrhythmia. RR interval would vary. No normal morphology of P wave, rather fibrillating P waves. And there can be 10 P wave followed by 1 QRS complex, or 5 P wave followed by not P wave, rather fibrillating waves followed by a QRS complex. So atria, since it is discharging at a random interval, so we have a fibrillating P waves. Some passes through the AV node and ventricular contraction happens, so we get a QRS complexes at a random intervals. So we have RR intervals which would vary. Okay, so this is how we recognize atrial fibrillation. Now, treatment of atrial fibrillation. How do we treat this condition? I will discuss once I have discussed atrial flutter. So next is atrial flutter. Now atria in atrial flutter is conducting at a regular rate. In fibrillation it was conducting at a random rate. Here at a regular rate, and rhythm is usually regular. Let's say atria is conducting at 300 times in a minute, and 150 impulses conducted by the atria is taken by the AV node. So the atrial rate is 300 and the ventricular rate is 150. Let's say after every 2 P wave I would get a QRS complex. Let's say 150 is not taken by the ventricle. Only after 3 atrial impulses, 1 impulse is taken up by the AV node. So after 3 P wave I will get 1 QRS complex, but the rhythm would be usually regular. Okay, so rhythm is usually regular, but sometimes it may be even irregular when the AV node is not conducting in a regular manner. So how I will get the ECG? So ECG would have typical sawtooth pattern. See, the P wave, the atrial flutter wave, P wave, has a typical sawtooth pattern. And in my ECG, every 4 P wave is being followed by a QRS complex. So if the atrial rate is 300, the ventricular rate is only 75 beats per minute, and the rhythm is regular. So this is atrial flutter. Now, what is the management of fibrillation and flutter? AV nodal blocking agent. We have to block the AV node. So AV nodal blocking agent, and either beta blocker or calcium channel blocker can be used. Now, there are sometimes some clinical condition is producing fibrillation, atrial fibrillation and all. Then rather than treating atrial fibrillation, we should focus on treating the clinical condition which is causing it. Okay? Okay. So, next is supraventricular tachycardia. Well, as I told you that when the QRS complex is less than 0.12 seconds and the rhythm is irregular, but the non-sinus pattern, that is P wave, is not seen, non-sinus pattern, no P wave, then we call it it is most probably supraventricular tachycardia. So what is causing supraventricular tachycardia? Rather, before that, see this ECG of supraventricular tachycardia. The heart rate is very high, more than 100 beats per minute it should be, and no P wave is seen. No P wave is seen. So no P waves. So P wave is hidden in the T wave, right? Because of the high heart rate. So no P wave is seen. So this is supraventricular tachycardia. Now, what is the cause of supraventricular tachycardia? Most probably it is caused by premature atrial beats, and it can be induced by variety of clinical conditions like hyperthyroidism, stimulants like cocaine, etc. Even ethanol can. And there are many types of supraventricular tachycardia. One of the commonest one is the AV nodal reentrant tachycardia, in which normally from AV node the impulses travel to the ventricles, right, in one direction. But what happens in AV node reentrant tachycardia? The impulse travel from AV node to ventricles and back from ventricle to the AV node, right? A cycle is formed, a loop is formed. So this leads to a AV nodal reentrant tachycardia, all right? So how would we manage it? Management, in let's say 25% of the cases, it can revert back to the normal rhythm, normal sinus rhythm with vagal maneuver. Now, what we do in vagal maneuver, simply, we try to increase the parasympathetic tone, which would decrease the heart rate. So, how we do vagal maneuver? We can go for Valsalva maneuver, and we can go for carotid sinus massage. But for carotid sinus massage, before performing it, you should always like hear for the that there should not be any carotid brood etc. present, which would tell us that carotid artery of the patient is let's say stenosed. So we should rule out by auscultation. We should auscultate the carotid artery before performing the carotid sinus massage, and it is a very bad idea to do a bilateral carotid sinus massage. It should be done unilateral, right? We feel for the carotid artery and we just massage it by applying a constant pressure on it. Okay, so this will increase the parasympathetic tone and decrease the heart rate, and 25% of SVTs revert to a normal sinus rhythm on carotid sinus massage. If it doesn't revert by carotid sinus massage, then we go for the drug of choice is adenosine. Adenosine is an ultra short acting AV nodal blocker, completely blocks the AV node. And adenosine, let's say, is treatment of choice in PSVT. We give 6 milligram IV very fast, right? It is given very quickly. And if the rhythm does not become normal sinus rhythm with 6 milligram, we give 12 milligram the second dose IV. Now remember, 75% of the SVTs would become normal sinus rhythm on treatment with adenosine. If it is not getting managed with adenosine, most probably it is not PSVT. Okay, and there are some conditions in which we have to practice some precautions, like if patient is on dipyridamole or carbamazepine, then the dose has to be reduced to 3 milligram. If the patient has a transplanted heart, again the dose has to be reduced. And instead of peripheral line, if I am giving adenosine through central line, then again the dose has to be reduced to 3 milligram. Okay, so in this case, dose reduced to 3 milligram. And adenosine causes bronchospasm, so it has to be avoided in asthmatic and COPD patient. So it is contraindicated in asthmatic and COPD patient. If the patient does not respond to adenosine, then we can go for the AV nodal blocker, that is calcium channel blocker or a beta blocker. Got it? Okay. So this was our narrow complex tachycardia. Now coming on wide complex, QRS complex tachycardia. Again, there should be tachycardia. QRS complex should be more than 0.12 seconds. It's of 3 types. Monomorphic ventricular tachycardia, polymorphic and supraventricular tachycardia with aberrancy. Okay. Now remember that if it is a wide QRS complex, then the origin is mostly in the ventricles. 80% of wide complex or QRS complex tachycardia would be of ventricular origin. Very less with supraventricular origin with aberrancy. And it would be good that we treat it as a tachyarrhythmia of ventricular origin, right? Why? Remember, why we should consider all wide complex ventricular tachycardia as of ventricular origin, because ventricular tachyarrhythmias are life-threatening, needs to be treated fast. Supraventricular tachyarrhythmias, they are not life-threatening, they may be very benign, but ventricular tachyarrhythmias are life-threatening. And the drugs which we use for treating supraventricular tachyarrhythmias like AV nodal blocker, etc., would be of no use in ventricular tachyarrhythmias. So it would be just wastage of time thinking that it was a supraventricular tachyarrhythmia with an aberrant pathway. Rather, we should think it is a ventricular tachyarrhythmia of ventricular origin, right? Now, there are some things which can point towards the ventricular origin is ventricular it is ventricular tachyarrhythmia. Age. If age is above 35 years, that is older age. Patient has some cardiac comorbidity, like patient has a history of ischemic heart disease or congestive cardiac failure, like heart disease, history of heart disease. Family history positive. There is familial history of ventricular tachyarrhythmias. There is a chance of heart disease. There is a chance that it is ventricular tachyarrhythmia. ECG features. When we will get the ECG done, then there are few things which we may notice in ECG, like there could be a fusion beat, there could be capture beats, there could be AV dissociation scene, right? Then again we should think it is ventricular tachyarrhythmia, that origin is in ventricles. And Brugada sign, that is 100 millisecond from QRS complex to the nadir of S, right? That is peak of the R wave to the S is 100 millisecond. That is QRS complex, the late phase is more prolonged. We call it Brugada sign. And some people say it is typically seen in, some studies says rather, it is typically seen in ventricular tachyarrhythmia. That is tachyarrhythmia of ventricular origin. So Brugada sign is one of the things which we need to remember. Okay? But remember, think all wide QRS complex ventricular tachyarrhythmia as ventricular in origin. That would be safer in management. So, how do we recognize through ECG? Patient should have a high heart rate. The QRS complex should be more than 0.12 seconds, that is more than 3 small boxes, right? This, as you can see in the picture, is a regular QRS complex tachyarrhythmia. Regular wide QRS complex tachyarrhythmia. We call it monomorphic ventricular wide QRS complex tachyarrhythmia. It's monomorphic. All the QRS complex are of same morphology, but wide QRS complex and heart rate is very high. Okay. Then we can also have polymorphic ventricular tachyarrhythmia. That is, all QRS complex would not have same morphology. Patient would have tachyarrhythmia, tachycardia, and the QRS complex would be wide. How we would manage? Unstable, all of you know cardioversion, whether it is supraventricular or it is ventricular, right? Whether it is narrow QRS or wide QRS. Unstable means cardioversion. So if it is unstable, we would cardiovert. But if it is stable and the rate is regular and it is monomorphic, all QRS complexes of same morphology, then we can go for adenosine. We can go for adenosine since it is most probably SVT with aberrancy, right? If I am not able to clear the morphology of QRS complex, right? If the rate is also not clear to me, it is regular or irregular, always antiarrhythmic. We go for antiarrhythmic. 3 important antiarrhythmic is important. The non-specific antiarrhythmic, which decreases the automatics of the ventricles. Overall, it decreases the automaticity and decrease the impulse generation. The 3 important drugs: procanamide, amiodarone and sotalol, right? Procanamide, amiodarone and sotalol. Amiodarone is most popularly used. We give a loading dose of 150 mg IV followed by the 70 mg infusion, right? Irregular white complex tachyarrhythmia, if at all it is stable, which would be a very rare circumstances, we would go for expert consultation, right? So this is about the management of white QRS complex tachyarrhythmia. Now remember guys, if we have a patient coming with tachyarrhythmia, we have to see 2 very important things: whether the patient is stable or unstable. If the patient is unstable, immediately we have to cardiovert. If the patient is stable, depending upon the QRS complex width, narrow or wide, our management would vary. Okay? So this is how we manage a patient with tachyarrhythmia. Thank you.